be willing to spend a little bit more time, but be respectful if a person does not want to talk about what happened to them, but make sure that you address the issues of their headache the same way you would any other patient who has chronic headaches. The veteran population specifically, it's hard to give you a statistic because we say that coming back from the wars, those returning soldiers had an extremely high rate of headache in the early period of months after an injury. But Dr. Jim Couch from the Oklahoma City VA has published some very important work going out as far as 7 years, showing that a population of patients who, of veterans who have headaches will maintain those headaches for a very long time, and the other comorbidities that would go along, such as PTSD or depression. The work in military is specific. We're dealing with a population that's younger, ultimately healthier in some ways because their training requirements in active duty are very different. Veterans have a lot of issues. And again, it's not fair to say that all of them do. We talk about things in veterans like suicide rates, and the fact is the suicide rate in veterans is lower than it is in population. But I think our focus on the volunteer heroics that many of the veterans have been through gives us an added incentive to get really good at this. Then we have VA systems that may or may not be user-friendly because of either demand or because of the system itself and how it works can sometimes be difficult to penetrate. But a patient who gets good care at the VA is getting top-notch care. Really top-notch because the system really works when it works. So if I'm seeing a veteran for post-traumatic headache, I also want to make sure I understand whether they had headaches before they were in the military, because that seems to be one of the things that really determines if the post-traumatic headache is going to be persistent, and that's the term we use. We don't call them chronic headaches, we call them persistent headaches because of the injury. If they had other injuries, other head injuries, many of the veterans before they entered into military service were athletes. Some of them came from rough backgrounds where they may, I think specifically in the hundreds of active duty soldiers I saw down at Fort Bragg, there were lots of wrestlers and boxers. Multiple martial arts are practiced in the military. They actually have fights on the base. I think active duty soldiers can figure out ways of clunking their head that humans never think of. So at Fort Bragg, we have something called the 82nd Airborne. These are the people who parachute in to the war zones in large numbers. And so they will have operations, training operations, where hundreds of soldiers are jumping out of the airplane. And usually 2 or 3 days later at the clinic, we would see a lot of these guys coming in because they had a hard landing. How that translates into the veteran life is interesting too, because I think the post-traumatic complications and persistent post-traumatic headache amongst veterans can be really devastating. It can really be devastating to their lives. Some of the quality of the VA system has to do with how it's set up. So there are large VA hospitals in places like New York, Chicago. Durham, North Carolina has a very, very good VA associated with Duke University. Oftentimes they're associated. I trained in Buffalo, had a very large VA. I also trained in Birmingham, Alabama, had a very large VA. They are on the campus of our hospitals. So that access is oftentimes better. But the system has to take care of veterans all over the country. So they've developed small clinics in areas more than 50 miles away from a major facility. And I think that is where there may be a problem of service, because the people who are staffing those may not be as aware of the complications of head injury and traumatic brain injury. And they may not be as well trained. So getting into the VA system, and I'm talking about from a personal experience now, having followed people who were in the Army, who left the Army, following them now in my private clinic and knowing their VA experience. And if I was talking to a veteran right now, or a person who's about to leave service, I would tell them to be prepared to have to wait to get in. And the traumatic brain injury or TBI clinics, headache clinics are just starting to be robust is the word, really starting to dig down. And so through the work of the American Headache Society, and specifically Bob Shapiro from Vermont, we put together advocacy program to work with the VA hospital, or the VA administration in Washington, and they've designated 5 centers of excellence for the study, treatment, and training in post-traumatic headache. So it took a long time. I mean, it took a very long time. But I think that they are underserved. And I think that part of that is also that the academic community is not as interested in this as they are in some other things. And that goes for all of headache. But post-traumatic headache is vexing to many people and frustrating to others. So in the VA, finding somebody who really loves to do this is not easy. We published a paper on the use of onabotulinum toxin, Botox, in patients with post-traumatic headache out of the population we were taking care of down at Fort Bragg of active duty soldiers. And we had a finding that was very curious. That was, the longer it took to get to treatment, the better off they did. It's a very curious idea that they were sicker for longer, but they had a better chance of responding. And the way we interpreted, and we talked about this for a very long time with the statistician and my other clinician scientists, the warrior effect meant that they had to be really, really sick in order to get help. And that translates into the veterans. They don't like to ask for help. They feel like they're intrinsically weak if they can't just kind of live through the stuff. And so that's a hard ask for us, to ask people who go into service with the mentality that they are going to be exposed to hard things, that they are going to have injuries, but that's what they're there for, is to serve and to have duty, and that the consequences of those should not make them a wimp. Okay, that they should be able to just power through. So they will wait longer, they will be sicker. And adding to that, your question about the how the access to VA compounds it all, because they don't get in as quickly as we would like them to. First question is, when did your headaches start? How did they start? Was it from an injury? Was it from a deployment? One of the really important studies by Jay Erickson and Brett Thiel from the Northwest was the first study that showed that just being deployed exposed you to headaches, and that 60 or 70% of those people coming back without injuries would have migraine-type headaches. So there is something about the exposure, and it may have been specific to Afghanistan and Iraq, and that environment was very, very stressful physically. But I would first ask them, did you have headaches before you were in the service? And if they say they did not have anything like a head injury, then I would ask them the regular questions that I would ask a civilian about sleep, about diet, about activities, and also about mood and how they're doing. Not every veteran, by the way, was in the war. You know, there were a lot of people who went to war, but a lot of people were stateside. Getting back to the idea of that the people I took care of, they figured out ways of clunking their head. This guy was unloading some fire extinguishers in Afghanistan, and one of them went off and just threw him into the back of the truck, you know, and he got knocked out. I don't see that happening in civilian practice that often. So I would make sure that I get a very detailed history. I would ask them, what are the headaches like? I would try to make sure I don't lead them towards migraine, but if they do have migraine features, which would be, again, throbbing pain, one-sided headache, headaches that are moderate to severe in intensity and worsen with activities, headaches that may associate with nausea or vomiting, light and noise sensitivity, that's the criteria for migraine. So they may have said to me, well, I didn't have headaches until, towards the end of a deployment when I was exposed to an IED. I came home, I had a lot of headaches, I had a lot of problems, physical problems, sleep problems. I ended up taking a medical retirement, and I've been in the VA system for 2 years, and they've tried these medicines on me, and then I would say, well, if you are not sleeping well, then you probably need some help with that, whether it's education or even sometimes things like medications. So the comprehensive history of a veteran is a little different because we have to take into account whether or not they've had injuries or exposures. One of the things that was very telling, and I have several patients who were from Desert Storm, which was the invasion of Iraq through Kuwait, we didn't invade, we just kind of stopped their invasion of Kuwait, and there were exposures to chemicals that were nerve agents. And so it took a long time for the military to know that, because people were coming back saying that and they didn't believe them. They thought, well, maybe, but we didn't know about this. And now it's being acknowledged that those kinds of exposures may have also caused people to have chronic headaches. So I would want to know what happened in service, what happened before service, what happened since service, and then what is this thing doing to your life? What is it doing to your family? What is it doing to your relationships, your ability to work? Are you disabled? Many of them are medically retired because they just couldn't work in the Army and they couldn't be deployed. So they may be unemployed. And again, they may have mental health issues. We call them behavioral issues or behavioral medicine issues in the military. And sometimes I'm the first person to recognize that. I'll see them for headache, and they'll start telling me about flashbacks, nightmares, and things. And I'll say, why didn't you tell your VA practitioner about this? He said, I haven't gotten in yet. I'm going, it's been a year since you retired. And they say, well, I'm waiting. The most effective ways are going to be, first, try to approximate that diagnosis. Try to determine whether it has those factors that may make it migraine type, and then treat it as if it was migraine type using the best available tools we have. And again, I think all the tools should be made available to both the clinician and the veteran. That's very simple and inexpensive medications that may also help with sleep, but it also may end up being, and there are ongoing studies of the newer CGRP antibodies for use in post-traumatic headache. So I want both the clinician, the veteran, and the patients out there to recognize that I'm not saying they became a person with migraine. They still have post-traumatic headache, but the post-traumatic headache may act as if it's migraine, and it may respond to migraine. We just don't have the science to tell us that that's absolutely true yet.